Hello and welcome to today's second webinar. And thank you very much for taking time out and being here today and also rejoining today's afternoon's webinar. My name is Young. I am the Marketing and Educational Seminar Coordinator here at NeoBiotech. I am also the moderator for the webinars, and this is me right here. Hello and welcome again. And today's agenda is very simple. I'll introduce our topic and the presenter and also make an announcement right after your lecture in regard to our special promotion for this webinar and also upcoming webinars, and watch previous webinars, and also how to receive your CE credits. So please don't leave and stay until the end. And let's stay connected with us on social media. Here's our Facebook page, is NeoBiotech USA, and here is the Instagram, it's NeoBiotech_USA, and lastly, our YouTube channel is NeoBiotech USA. So please follow us and share, also like all of these. So today's topic is Advanced Bone Grafting Made Easy with Dr. Jeffery Platt. And we'll also have a Q&A session at the end, so please submit your questions through this Q&A box right here. And one thing that I want to address is Dr. Platt may not answer all of these questions since we have a short period of time. Okay, then that's why I'm jumping to today's webinar. And let's have Dr. Platt to start. Good afternoon, Dr. Platt.
Hello, good afternoon. How are you doing?
I'm doing great. Dr.
Good.
Okay.
Welcome, everyone. I'm coming to you, the previous ones, I've come to you from my home. In Colorado, we're now authorized that we can begin going back to work. And so we're not just seeing emergency patients, we're actually starting to see normal patients and things. We're still trying to get through our urgent patients, but we're doing that. And so today, I've been busy. You know, we've changed the way we do dentistry a lot now, and just like you have, and so we're inventing this as we go, right? But for right now, I just barely finished up seeing patients and still have one in the office that's just leaving. And but I'm here with you, and I'm grateful, you know, that you've taken the time to come and be with you a little bit here today. Let me begin by sharing with you my screen, and I'll kind of introduce our topic a little bit as we go. The process itself that we're going to look at today is what I would term advanced bone grafting, and trying to simplify it. In my experience, what I have tried to do in my 35 years of dentistry is trying to make things easier for the patient, but also predictable for us to do. And so from a general dentist standpoint, you know, I try to do things or provide things for my patients that are very predictable to do, but yet also going to minimize their ache and pain, and see what we can do to do that. And so this technique that I'm talking about today, we'll share a few different techniques with you, but we're mainly going to focus on one particular one. And so we'll begin with that. But first, let me just review from my standpoint the basics of bone grafting. What do you need to do in order to grow bone, whether this is in a socket, whether this is horizontal or vertical growth? What are some of the basic things you need in order to grow bone in somebody's mouth, at least here in Colorado Springs? And so the first thing you need to have are the following. One, you need to have a good recipient site. In other words, you need to be able to identify the area where you want to grow bone, and you need to be able to visualize what that new bone is going to look like when it's there, and what your goal is for that. The recipient site, will get a little bit further into that as far as what is a good site and others. And I'll say this, that now the majority sites can be all good, rather than just a few good sites. The majority will be good. The other is that you have to have a blood supply in order for bone to grow, particularly on nothing. If you're trying to grow horizontal bone, you have to have blood supply that's coming from the jaw itself, and the medullary space and the medullary bone into your graft site. If you have a blood supply that's going to grow there, then that is a vital portion of the ability to be able to feed your new graft, and then also allow that graft to go through all of the processes that we need it to in order to become hard and dense bone. You need to be able to immobilize that graft material that you put in there. If a graft material is going to move around and be unstable, then at that point it will not take, or will be minimal in its take. And so being able to immobilize your new graft material is also a third key. A fourth one is, in my opinion, and this one can be somewhat controversial. You may find others that may talk differently about whether you need to block out the epithelial growth of the gum tissue into the graft, but I feel that for best results, if I can place a barrier that will be there to help keep that epithelial growth from growing into my graft material as this is healing, then I find that I get a little better results. And then the last one is the time. It needs a certain amount of time to heal. And generally, you know, for this technique, we're talking about just a few months, maybe 3 to 4 months worth of time. We're not talking a year of time for that. And so the majority of times when I am looking at doing these techniques that I'm going to visit about today, I will place the graft, and then I'm going to take a cone beam of that in about 3 months. And usually at about between month 3 and month 4 is when I'm ready to place implants in there. And so those are the basic things that we need to have, you know, for that. Now, we need to also have the proper amount of materials and the correct type of materials that's there. And by that, what I am not saying that you need to buy everything from every vendor that is possible out there that you can use to grow bone with. That is not what I'm talking about, is doing that. But instead, what I'm talking about is that the same materials that I use in my socket preservation, I use for my horizontal bone growth. I use the same type of material for that. There may be a little variety, but I have the same materials that I use for the majority of the grafting that I do. And so finding a good success for materials that you have that will work in a variety of different circumstances, that's what I'm talking about, is a key principle. The other thing is trying to keep it simple. I feel too often we try to make things very difficult, and we try to add so much to this, that I'm doing this, I'm doing that, I'm changing this, I'm adding this to this time and this to this time, and changing it that we forget just the KISS principle of trying to keep it as simple as we possibly can. And so what are some of the things that you need to just keep it simple? You need bone. The majority of bone that I use for me personal is cortical powder. I want a small bone, and I like the cortical because I get a more dense bone growth that's there. Now, having said that, I know that that's even controversial, because you're going to have a lot of variety of opinion between cortical and medullary and particle size of that. And so for me, in my office, the cortical powder works better for me, because at that point I can condense it. I can get a good pack and a good fill with that. And if I've got good blood supply that's coming, then my cortical powder is going to grow. Another is membrane, in having a certain type of membranes, or membranes that are available to put into place. Typically, the majority of time I use a resorbable membrane, and I would say that's probably about 90% of the time I'm using a resorbable collagen type of membrane. Sutures, my favorite suture that I use is a 5.0 in Vicryl, or the Generica Vicryl, or PGA. That one I like because it can be used for smaller type of sutures that I can use. The Vicryl itself I can use as an internal suture that can be there for upwards of 3 months to help stabilize a membrane if I need. I can also use that in my tissues, and it does not wick in bacteria, and is a good material that I find that I enjoy and like a lot. And so that is my go-to suture. And then if there's going to be a specific type of procedure that you're doing, then the kit that you would need for that. For example, we're going to talk a little bit about doing a ridge split. You would need to have a ridge split kit for that, and that's what I'm referring to at this point in time. And so knowing where your blood supply is coming from is a big key for me to suggest to you in trying to get your bone to grow. And so if on the top row here, we're looking at an extraction socket or at a sinus lift that we will be doing. Typically with that, we're having a 2 to 3 wall or a moat type of defect that we're filling. We're getting blood that's going to come from all the way around this particular extraction site. In the sinus area, we're getting from the medial wall, we're getting from the lateral wall, we're getting from the inferior wall. And so we're getting blood supply that's coming from a variety of places. When we start to look at other areas, like on the bottom, at this point, we need to have a blood supply that can only come from underneath. You know, if this is our graft that's being placed on top, this is our only source of where we're getting blood supply that's coming. And that blood supply has to come up and penetrate enough up into this graft material that it will allow this graft material to begin growing. And so knowing where our blood is coming from and the blood supply is coming from as it comes through the bone itself into our graft is a vital part of knowing and being able to get that blood supply to go into the graft. Preparing the bone. As we prepare the bone, this is how I typically would prepare it, is making some sort of openings into the medullary space. Now with this one, you can see I've got 3 points here that are bleeding and 3 that are not. You need to have all of the sites that are bleeding. This does no good to us. You know, this is not going to allow nutrition and the building blocks to come from the inside part of this medullary space to the outside of our graft. This will allow the building blocks to come in and to begin growing bone. And so if we were to just leave this like this and graft it, we would get good bone growing here, and we would get maybe minimal bone or no bone growing here on this side of our implant. And so making sure that we do have a blood supply that is coming through the openings that we're making in the cortical plate is a key for that. This is more of what I'm talking about. And so having a site that all of the penetrations that you're making through the cortical plate, every one of those have some bleeding that's happening. If I find an area that is not bleeding, then I will go a little bit deeper and penetrate deeper through the cortical plate in order to bring that blood supply to the outside portion of the graft. And so if we can predictably get a bleeding site in an area that we're getting blood to come through from the internal part of the patient to the external new area where our bone graft is being placed, we will have a predictable bone growth that will happen like this. And we can see that consistently, and we can make sure that that's going to help us out. And then at that point, we would feel comfortable placing an implant into a narrow ridge like this, knowing that we can grow bone around that implant. And so in order to do that in this particular case, we're using a membrane. And the membrane that we're using is a titanium-based membrane that would attach onto the implant itself and the body of the implant. What we're using the titanium membrane for here is to stabilize that particular bone graft that's here. By having this bone stabilized, that holds it in place, and that allows the blood to come into and to penetrate through and begin to move through the variety of steps that it does from a graft to woven to laminar to actual bone that's going to be dense. And so this, by using the implant and using the titanium mesh itself, will allow us to help predictably gain a process of grafting. The membrane itself that Neobiotech has is called the CTI membrane. This membrane is a predictable membrane to use and is one that has had good success with treatment of that. Again, there's a variety of ways that you can stabilize that membrane from the standpoint of the cover screw that's coming over to a lateral screw that's going to come in to stabilize that membrane. There are a variety of things that you can do in order to help achieve and accomplish that bone growth that you need in order to place an implant. A second type of a membrane that can be used that I use frequently, and I'll describe more in this particular technique of the tunnel grafting, is that of using a collagen membrane. That is either a resorbable or a non-resorbable. I do have some non-resorbable here in my office, but I will be honest with you, the majority that I use is a resorbable membrane itself. And with the technique that I'm going to show you and teach you today, it's something that we all have a resorbable membrane in our office if we are doing any type of bone grafting. The non-resorbable membrane has a titanium reinforcement that is placed, and the purpose of this titanium reinforcement is to help hold space so that the bone graft underneath the membrane doesn't get moved or displaced out from under the membrane, but that this framework will actually hold the space while this bone graft and part particulate that's underneath here will adhere and will begin growing, and then will stabilize and then become the new part of the bone recipient site and the bone graft material for our future implant. And so using a non-resorbable will help to stabilize that bone graft and keep that bone graft from moving and changing its position and thus not incorporating. An Onlay graft. I just barely saw a patient moments ago. The last patient I saw was one that had an Onlay graft that was done by the military. We have a lot of military here, and he was looking to get his implants done hopefully before August. He just had an Onlay graft that was done about 6 weeks ago, and at this point he's going to have to wait a while before he's going to be able to get his implants done. I told him if he would have just come and seen me first, we could have been doing and had his implants in and restored by 3 months, but that's okay. You know, he's going to be a little bit behind with everything, but onlay grafting is a process that can be done. I don't do onlay grafting anymore, and I'll show you the technique that I do that has replaced my onlay grafting. But onlay grafting is a successful technique. It has been used frequently and often, you know, for a lot of voids and a lot of defects that are there. Essentially, you're taking a graft or donor bone itself and filling in or placing into the recipient bed. After the recipient bed has been prepared, you still need to have bleeding that's coming through to this donor bone as well as with any donor bone. And then once you've got that stabilizing in place, then typically I choose to place a secondary graft or particulate graft around that, and then finishing up with membranes that would go over the top of that. The Onlay graft has been used for decades and has been stabilized and has been used and has been talked about in multiple sources for that. And so if Onlay grafting is the choice that you would like to use, and then continue to do that. I'm not saying that that is not a good technique, because it is a good technique and it has been used a lot and has been very predictable. The technique that I'm going to teach you is one that we can potentially help to replace the Onlay graft and do that differently. So that way we would not have to have a recipient or a donor site from the actual patient itself. And so we'll look at that. Another technique that can be used to get some advanced bone grafting is a ridge split. Ridge splitting itself is used to literally divide the existing ridge that is present and causing that ridge to move, particularly and mainly it moves to the buccal. You may get a little bit of movement of that to the lingual, but the majority of movement that needs to happen with a ridge split is that it needs to move to the facial surface of that. And splitting the ridge, dividing that, and then moving or separating that or expanding that ridge is part of the ridge split technique that is used. And that is a predictable technique and is one that I have used a lot too. Neobiotech has its own kit that is used for that, and it's the Ridge Wider kit. The Ridge Wider kit comes with saws like you see over here that are used to divide and to create an incision through the bone, and then from these incisions through the bone, there are bone expanders that are driven into the osteotomy sites where the future implants will be placed. And then those expanders are used to actually begin moving that segment of the bone. And like I said, typically we're wanting that to move to the facial surface. Is where we get the majority of our recession of bone and loss of bone. The kits themselves have have other things that are used or utilized in this that we could go over. This is essentially a day course to go over the ridge splitting, to know and understand how to use a ridge split kit with that, which can be done, and it's a great course to have, and a good armamentarium that you can have as an extra opportunity when needed. The ridge split itself is done by dividing and creating releasing incisions as well as a coronal incision. The coronal incision has to be made all the way through the cortical plate and into the medullary space. Cortical plate is going to move some. The medullary bone that's there is going to be able to be compressed and expand that cortical plate. As this cortical plate gets expanded by the expanders that are coming in, that moves that segment of bone to the facial, and then also as you place the implants there, it moves it even further. It's a slow process of getting this bone to expand and to slowly move and to slowly position itself so that it will be in a lateral position. It is not a technique that you can do quickly, or else you will end up fracturing off, you know, these segments of the bone. And so I like to go slow with this particular technique itself. It is one that I suggest that with the releasing incisions of bone and in the coronal incision that's made, that these two corners meet. In other words, that you make the incision through the bone and the releasing incisions all the way from the coronal portion down, so that this segment of the bone frees up completely. And if this whole segment of the bone is freed up completely, then that's going to allow that to expand and to move. Releasing as far down as the implant is typically what I do suggest with the length of your releasing incisions themselves. The tunnel technique which is what we're going to spend the remainder of our time here, is looking at this. The tunnel technique is not a new technique. It is one that I learned when I was in dental school. It is a technique that has been used for a variety of things, in adding extra gum tissue underneath, of adding bone underneath. So this is not a new technique. This is a technique that I have added some changes to in order to make it predictable. And so that's what I'm going to show you, is what I do here in the office. What it allows us to do is it allows us to go from a ridge on the left, which is the before, which essentially gives us just a small, thin, almost needle-like shape of bone that's remaining. And with this technique, we can fill in this C defect right here, and we can get bone that will grow just like this over here. And so we can have this segment of bone grow with this particular technique itself, and not have to be done with a block graft that's there. Excuse me. And so we first start off with anything just with the cone beam. And so the cone beam itself is going to give us the example of the ridge and what we're looking at with ridges. We've seen lots of ridges just like this. If we have this height that's here, we're amazing, and this is great. If I can get a height that is this amount or implant length, then at that point, this is a slam dunk case to grow bone here on the outside, and literally to grow what I call an exocytosis, or grow tori in the area where I need to grow tori. And so I am not talking with this technique of growing a little bit of bone like this. Another millimeter of bone is going to do us nothing except cause irritation to the patient. You know, this patient needs to have, 6 to 8 millimeters of bone growing, on the facial surface of this in order for us to consider placing an implant. That's what I'm talking about, is growing that amount of bone in this area on this patient, so that we're going to be able to have space and a place to place our implants that are going to be predictable. The other thing we need to do with our cone beam is we need to be able to see any vital structures that are there. If we're bone grafting and the majority of this is all done on the facial surface, we have to know where the mental foramen is for the lower. On the facial surface, we need to know, essentially, we need to know the architecture of the maxilla. And knowing the architecture of the maxilla, that's going to be the main vital structures of the maxilla that we need to know with this particular technique itself. But knowing where our vital structures are is important. And in using this, particular technique, this is another perfect site that we can have, that we can get bone growth that would happen here on the facial in order for us to have plenty of bone to place. With our cone beam, we're also wanting to visualize the entirety of the space that we need to grow bone. If we're growing in between teeth, or if we're growing in a distal extension, we need to know that whole surface and the whole area. We need to be able to almost memorize the bone structure itself, because with the tunnel technique, this is a blind technique. You will not see the entirety of the bone. You will see small little areas where the tunnel will extend and will come through the tissue, but that's it. So I need you to know and memorize the area that you're going to be doing surgery on before you even make your first incision. And so you need to know the areas where the medullary bone is. You need to know the thickness of the cortical plate that's here. Is it all even? Are you about 1 millimeter or less of cortical plate? Are there areas that it's 2 to 3 millimeters of thickness with that? You need to know that for the area of the graft recipient site. I began this technique with doing root coverage. And so I started this technique when I was looking at covering root surfaces that had had some severe recession on them. And from this particular technique, and I'll show you a little bit about this too, we start off with a tooth that is like this, that has some excessive recession, and getting coverage. The main thing that we need to have with this technique for that is we need to make sure that we do have a minimum of 2 millimeters of attached gingiva that's here. And so if we have a minimum of 2 millimeters of attached gingiva here, at that point, this technique will work well, and we'll be able to get full coverage of these particular roots and the surfaces there. I start by scaling and root planing, and then I'm going to flatten the surface of the root with a round burr. If there happens to be a composite that is here, I'm going to remove all of the composite and get down to the root surface. Once I've done that, then I'm then going to rescale and root plane, and then use some EDTA on a cotton pellet. EDTA is just an agent that begins and allows and helps gum tissue to heal and to grow a little better onto the root surface itself. And so the EDTA is used just over the root surface, and then at that point I'm ready to begin the tunnel process. Incision. Where do you make the incision? This is a one incision or a couple of incisions based upon the length of the bone graft site that you need to have. The incision itself is made in only mobile tissue. And so if you have attached tissue that is here or right here, you are not making this incision up into the attached or keratinized. It begins at the mucogingival junction, and from there it goes apical. That's where the incision is placed. And this incision is made so that it is big enough that you're going to be able to get instruments in. And I'll show you also the bone carrier that I use. It needs to be large enough to do that. Typically, that incision that's made is about 10 millimeters in length, 10 to 12 millimeters in length. And that would be long enough that it would enable you to get instruments in, and then also enable you to be able to get the bone graft and particulate in. And so on this patient, we're looking at where is the keratinized border, and then at that point, we're making our incision there. The second thing that we're doing, if we have a C defect like this, we're going to make our initial incision on the tooth in front of, or mesial to the defect. This area mesial, we want to be at least to the mid area or mid facial of the tooth in front, excuse me. And so we're going to come, let me back it up. We're going to come and make our initial incision on the tooth in front, or the tooth mesial to that, so that the area of the defect will be able to be covered by the bone graft, and we'll be able to extend our graft from good solid bone and a good stable bone back to good stable bone, so that it will be able to fill in this void here. And so by doing that, that's going to allow us to have our implant, if we were looking and considering placing it here, which would be the appropriate site if we did not have a bone graft, and place in the lingual root area, we're going to now be able to move our implant to the proper place and center that implant where it should be, because we now have bone that's going to grow out to the extent that we need it to grow. And we can do multiple sites at a time. And knowing where the mental foramen is, we know that our mental foramen is right down in here. It's going to be right in this area. And so we have to know where that is. Sometimes I will actually take and will draw and palpate the mental foramen so that I know exactly where it is. On my cone beam, I'm going to actually measure the space down from the top of the gum tissue down to the most coronal portion of my mental foramen. You're wanting to stay a minimum of 3 millimeters away from that mental foramen. This is not something that you're wanting to come in and explore or probe the mental foramen. You're wanting to stay away from that. And so knowing where that is in order for you to do your bone graft and to do your tunnel is what I said before is one of the main things that you're wanting to do with your cone beam. And so being able to know where it is, this is where your incisions would come. Your incision would come mid-facial of these teeth right here. Next, it can be done for full arch. And this technique can be used if you're looking at someone who has a thin knife edge on a lower denture and you're wanting to place more than just minis there, but you're wanting to restore. This technique can be done multiple times and it can be done for a full arch. The minimum distance between your incisions would be 15 millimeters is the ideal. And so you would come and make an incision right here in the midline, and then 15 millimeters to the distal on both sides. And again, 15 millimeters distal to that would put us close to the mental foramen area there. And this would enable us to then extend this back into the first molar region. If you needed to go even further distal than that, then you could do another incision distal to the ones that are there. But this particular technique I've used to grow bone on a lower like this, where it has a knife edge, and it can be done also very predictably too. The incisions themselves are similar, but the spacing of that is what we need to look at to make sure that we're going to be able to get access to the bone underneath. To get access to this bone right here, we need to have a window here and then another window here. And I'll show you more about what we need those windows for. We can take on a patient that we're using in the cosmetic area. I typically like to make my initial incision right in the frenum itself. By doing that, I'm kind of giving them a little bit of a frenectomy, but I'm also going to hide my scar a little bit better. And so I like to come into the frenum in this area, and then after I've done this, now I'm going to begin tunneling through this C defect back to this extent of this tooth right here of the canine. And then from my initial incision right here, I'm going to tunnel through this and then back around and underneath the C defect and get back onto good bone itself. And so this is a technique that as I'm looking at finishing up my orthodontics, then at that point, I'm ready to begin growing bone. If I'm about 3 months from the point of finishing the ortho or more, I'm ready to come in place and to do my bone graft and get the bone growing and get that ready to place. Oftentimes, I would like to place my implants just at the final steps of my actual orthodontics that I'm doing in order to remove my orthodontics, make the crowns and retainers and everything at the same time. And so midline is where I'm going to make my initial incision in a cosmetic area. Creating the tunnel, how do we do that? So first of all, I'm going to give you something that you probably already have, and that's a Molt 2-4 curette. We typically have that in our offices already, and we use that for debridement of a socket or of an abscess. And so that's the instrument that you're going to use for the majority, if not all, of the entirety of this particular tunnel itself. It starts by coming into our incision line right here with the 2 end or the small end, and we begin the process of lifting and moving the tissue and creating that tunnel. As we continue to move on, we need to make sure that the tip of that molt is staying directly onto bone. We want to be under the periosteum. This is not a split thickness flap that we are making. This is a full thickness flap that we are creating that is going to separate the periosteum from the actual cortical plate itself. That is the goal of this for the entirety of the tunnel itself. And so as we begin the process of opening and creating our tunnel, it's a gentle step that we're doing. Once we get underneath that, this step starts to go faster. But the initial entry point right here is where we have to be a little bit careful. We have to make sure that we're not going to create a split thickness graft or flap that's there, excuse me, but that we are going to be able to move our periosteum and move that up with the mobile tissue itself. And so being able to recognize the periosteum and know where that is and what that is so that we're getting underneath that is also a key. Then we continue to extend the molt distal until we get to the point that we've created or come back to the next tooth distal, or we've come to our next incision line. We're going to extend all the way through so that we have lifted our tunnel in entirety here. Once we've taken this and we've created the tunnel in the mobile mucosa, now we're ready to detach the keratinized or the attached gingiva and lift that. And so first we release the mobile mucosa, then we come and release the attached mucosa. As we continue, we're going to extend back, like I said, to the next defect, to the next tooth distal to our defect. The purpose of that is so that we're having good bone on the mesial, good bone on the distal, so that as we place our bone in our membrane there, it's going to have a place to rest, and it's going to have a home that it will allow the bone to begin growing and then to fill in the void in the space that's there. In a distal extension, where we're missing teeth to the entire distal of that, we're going to create again a window that's going to come in, and our window is going to extend. An initial incision is going to come here, and then we're going to extend this down and out to the facial surface of this. Typically, it's like I said, it's almost always the facial surface that we're losing bone, and this technique is the process that we're going to grow bone right in this area here to make it wide enough that we'll be able to place our graft. We can see in this particular tunnel that we've created a space, and we've got a good tunnel that we've created so that we can take a perio probe and insert that in and measure and know exactly the length of where we're going to. When we remove our instruments from that, it's going to sit passively there. And so this passiveness of sitting is going to allow us the space that we're going to place our bone and future graft of that. If you need to create some vertical, you would take your same 2-4 molt and then go over the top of the ridge. And so as you're releasing the keratinized here, you can then go over the top of the ridge as this example here. And then as you've released this, now you've created a space that we're going to be able to pack bone into. And as we pack bone there, we're going to be able to get growth that's going to happen in the vertical direction. Blood supply. How do we get blood supply in the tunnel? Well, this is the part that took me a little while to figure out. But if we had a full flap that's done in a traditional flap like this, we're going to want to make holes. We're going to take a 1/4 round burr is what I typically take. And then from that, I'm going to punch holes in here. And as I punch holes in there, I'm getting bleeding like we talked about before. We get lots of those punched. But what I don't want you to think of is just doing a pinpoint area. I also want you to consider that I could remove a longer area with my round burr, or I could connect areas like this. By doing this particular type of a opening, we have now created a large space for blood supply to come in. And so if we did something like this, an oval that we were overlapping, and we did an oval here and an oval here and then an oval back here, we could essentially get a great blood supply to this whole area here. We don't need to worry that we've removed the cortical plate because we're going to be grafting over this, and this entire area is going to be covered with bone. But we do need to make sure that we're thinking about trying to get blood supply about every 8 millimeters. Or actually, if we think 6 millimeter spacing, we'll probably end up getting 8 millimeters. So think smaller area rather than larger area and occasional openings into the medullary space itself. And so the way that I do that is I take a 1/4 round burr either on a surgical handpiece or on a pedo handpiece. The smaller the head, I find works better because I'm already going to be tight on space. I'm taking that quarter round burr with copious amounts of water, and I'm going to visualize the space where I need to create my opening into the or through the cortical plate itself. And then I'm using a variety of things. One, you can use either a perio probe to lift the tunnel up or lift the graft up, or two, this is some cotton pliers. Now, don't use your best cotton pliers that you're wanting to make sure that you have, good serrated edges on these. Use the ones that, you got sitting on the side and you don't really like, they don't really hold things well. Keep those. These are great because your quarter round burr is going to hit your instrument there. And as you do that, you don't want to use your best cotton pliers. But cotton pliers work well to help hold and to open the tunnel. Using a perio probe that you're going to extend into the tunnel is another way of doing that. And so you're going to open up the tunnel, and then from there, you're going to insert in your handpiece and your burr. A great assistant that can retract the lip and cheek works perfect for this particular technique to help us out. Let me talk a little bit about sponge bone. Sponge bone is something that I was turned on to by Dr. Sam Lee. Dr. Sam Lee talked to me about and taught us a little bit about sponge bone in a particular seminar that I attended from him. He uses sponge bone or recommended that to be used in this particular case where you've got an area that you've got a pontic that you need to create some space, and or a larger area here that's a single rooted tooth that's going to create a large space for a graft. And so with this particular patient, this patient's wanting to end up with a couple of implants here. And this ridge has been resorbed down to the point that there is almost nothing that's left of that. There's a small amount that's present, but there's not enough that we could place an implant there. And so first removing the tooth and degranulating everything, then creating our pores or openings in through here is always a key, because this becomes our source of medullary space and bleeding that's coming in. And the sponge bone is placed here to the outside. It's filling this space. Once this is there, sponge bone can help hold space. It can help create an area where we're going to gain vertical height. And so it can hold gum tissue up to help create the vertical. Sponge bone, I get that from this particular website, the vdsgadget.com. And so that's where I get my sponge bone from, is from this website. They have just a lot of gadgets and gizmos and other things that you can use, but that's where I have found that I can get my sponge bone. The sponge bone itself is placed in, and then a membrane over the top. And then this particular membrane is a resorbable, or a non-resorbable membrane, excuse me. This non-resorbable membrane is placed into the area, and then 2 weeks later, the sutures, actually 3 weeks later, sutures are removed, and then this area is going to stay exposed until the sponge bone will grow in. I find that with the sponge bone, I have less loss of bone when I have an exposed membrane than when I have a particulate bone that I've placed and an exposed membrane itself. And so with this one, you can see that at the removal of the membrane and then the regrowth and recheck of this back, we even left that open, and that continued to granulate in to the point that we now have keratinized tissue that's over the entire ridge itself. So the sponge bone will grow an adequate width. It can be used to grow height also, so that there now is enough space and place that we can place implants into this area. So implants were placed, and in this x-ray on the left shows us the ridge before, which is the outline here, and then the sponge bone that was added, and the growth of bone here to the labial surface. And so you can see from this that now we've got enough bone that we could place an implant ideally where we would like to have it placed. So back to my tunnel technique. Okay, let's hit that again. With the tunnel technique, the reason I say that we are placing incisions at 15 millimeters is that we're going to create or cut a square. The square of our collagen membrane is going to be 15 millimeters by about 20 millimeters. Sometimes, depending on the space, it can be a 15 by 15 square. But that 15 millimeter square typically is a length that you can purchase. And so I do that and then have my assistant square that off. Then secondly, I'm going to grab that, I'm going to roll it up into a little bit of a paper airplane, or make a cone out of that. And I'll show you why the cone is going to be needed. And so on the cone, I'm grabbing the two corners here, rolling that together, and then placing it in. It goes in just like this into our tunnel. Once this is placed into our tunnel and left, at that point, here is the space that we're now going to provide the area where the bone graft is going in. This process of placing the membrane is a quick step. So you have your bone ready, it's already drained, it's ready to go in and be inserted. You take all of the tips off of your bone syringes. You're going to have that ready that it can be placed in immediately once the membrane is. So the membrane comes in and with your cotton pliers is placed to full length, which is the 15 millimeters or more if you need, but it's placed in the full length of that and then followed quickly with bone that's going to be inserted. If you happen to have your membrane collapse, and this is probably the one thing that may happen at the first when you do this, is that you may not be quick enough. Your membrane may get soaked with blood and then just collapse in. You can remove the membrane and insert another one in. Membranes are relatively cheap and inexpensive with the collagen membranes. But I insert it with a perio probe that I will hold the tissue out. And as I hold the tissue out with this, I'm going to insert that in. I'm keeping my perio probe in so that there's the space that I can insert this all the way to the extent that I want to have my defect filled. And then I need to hold the membrane. So once I've inserted that, at that point, I'm pulling my perio probe out while my cotton pliers are still in. And then I'm going to insert my perio probe into the tunnel area and then remove my cotton pliers. So let me review that again. So first, my perio probe is used to hold the flap out while I insert the membrane. Once the membrane is inserted to length, I remove the perio probe and then place it inside of the membrane itself. And now I'm going to use this perio probe to hold the membrane and the tissue out while I insert bone. Bone is then added this way. So right here you can see I've got both my membrane and I've got my tissue, and here I'm injecting bone or inserting bone into that. The bone gets inserted in until I get resistance, until it's full, and then I'm going to pack. And I take either the same bolt 2-4, or you can take another condenser if you would like to. Make sure that that condenser has not been used on any amalgam itself, because we don't want to cross-contaminate that. And so make sure that that condenser that you're using to pack is one that is new and is only used to condense bone. That's my 2 cents about that. And so we add bone, then we add more bone and condense until we have the entirety area here filled and it's dense. And we've created, in essence, our new tori that's there. After you've placed the first couple of bone inserts in, you can then remove the perio probe, because now your bone is going to hold the space and create that. And then you can just come and pack bone in and place more in and pack more in. We pack that until the tunnel is full. When the tunnel is full, at that point, we've got a compact bone graft material. We've got a membrane that's holding that and that's creating the tunnel for that the top of the membrane is coming to the occlusal portion of the ridge. The bottom of this membrane is coming and making contact on the bone on the opposite side. If we're wanting to fill the ridge itself, then this membrane needs to be a little bit longer from apical to coronal so that it will fit up over the occlusal portion of the ridge itself. And then after we've done that, then we're ready to suture. Like I said, I like to have my Vicryl or 5-0 PGA. We're closing up this tunnel that's right here. If we're doing grafting of root surface, we may do a gathering stitch right here to loop around the lingual of our crown or of our tooth in order to just hold this tissue up a little bit. most often what you'll see is like this, that as you place the bone in the membrane, the tissue itself will come right up to the ideal place that it needs to be. For extensive ones, like I showed you here, that had, you know, 8 millimeters of recession to 9 millimeters of recession, you might need to have a suture that's going to hold this neck of the attached gingiva just right up next to the tooth itself in the CEJ area. After we've done our interrupted sutures and we've closed it up, then essentially we're done. And at that point, we're letting this grow and we're letting the bone heal. And for this process, we've created everything that we need to. We've created a recipient site. We've created a blood supply. We've got an immobilization of that because we've only opened the tunnel up enough for the space that we want to have. If you want to grow a big exostosis, open this tunnel up a lot. If you want to create just enough to fill bone here for 10 millimeters, then open it up 10 millimeters here. But however large you open this up, that's going to be the space or the size of the tori that you're going to be growing. And so here's an example of the tori that was grown. And so this is a pretty good sized tori that's grown. Oftentimes at the beginning steps, you're going to then come back and trim this bone back because you've got too much. Once you get the technique down that you've been able to determine how much width do I need to have, then you'll be able to have less and less space that you're doing in order to keep a good condensed and tight tunnel that's going to be there. But you can eventually get it to the point that like this, that you can do a tunnel on this one, and you can restore the normal anatomy and not develop two tori out here and another tori here, but you can then just have a normal architecture of the ridge, and the gum tissue will fit. Like I said, if you get too much, you can always come back into surgery or the implant placement and trim that back. But this is a normal process of doing that. And so in placing this implant, we're placing this implant right here at this junction point. If there's any point that if this was a block graft that it would detach and come loose, this implant just now became a wedge that's in there. But it does not do that because we've got blood supply that's coming in from the medullary bone from the top all the way to the tip of the apex of where our bone graft is coming. And with this blood supply that's coming in here, this is supplying and growing this new bone in this area. And so we can now create space that we want to have. We can create width that we want to have. If we need to create some more height, we can get some height. I'm not going to tell you you're going to get 8 to 10 millimeters of height with that. So please don't think that. You can get 2 to maybe 3 millimeters of height with the sponge bone and with packing over the ridge. But the width, you'll be able to grow anywhere between 4 and 8 to 10 millimeters of bone from the facial surface to fill in the void and defects that's there. This is an example that I just barely placed an implant on Monday that we started with 3.7 millimeters of bone. We grew a tori that's here, and then we placed our implant right in the middle of this. It is so much easier to be able to angle an anterior implant and put it where you want it to be so that the tip of your implant is going to come out the incisal edge of your adjacent teeth rather than trying to place it completely to the lingual because you don't have any facial bone that's there. In looking at placing an implant here, yeah, you could probably place a little mini here, but the angle of that is going to be hard and awkward, and you're not going to be able to have an ideal place in position of that. Growing bone first and then placing the implant where you want it is the way that I'm suggesting that this can be done. This is another example that I've got of some recession that we covered recession as well as added onto the ridge here so that we can now have enough bone and an implant can be placed in. Again, our foramen and knowing, our foramen and knowing where the foramen is and staying 3 millimeters away from that opening is what I wanted to show you with this. But you can create bone that's going to grow in this area where there is recession. And not only that, but at the same time, you can cover recession. You can also grow bone to place implant in areas where you're missing. Last couple of slides here is some postoperative meds. What do I send people home with? I always send patients home with an antibiotic that I'm doing a bone graft on. And so this is my choice. My first choice is amoxicillin. And then with these, I just send them home with Tylenol and ibuprofen or Tylenol and Aleve. That's all I send these patients home with. I don't do anything more than that. If there are complications that happen, in other words, if there's an infection that gets into the graft or into the gum tissue area, then I would switch the amoxicillin for augmentin and flagyl that I add at the same time. By the combination of both of these two, that's going to create a scenario where you're going to be able to have better results with an infection that may come in. So of the techniques that we've talked about, which ones do I use and when? If I have a patient that needs to have and wants a quick implant in place as soon as I can, I'm going to use the ridge wider kit and do a ridge split. If I have a patient that there is a noticeable cosmetic defect, I'm going to use the tunnel for that to help create back the architecture. If I have time, in other words, if I have 3 to 4 months worth of time that I can place a bone graft and let that heal, I'm going to use the tunnel technique itself. If I have an implant where there are threads that are exposed, I'm going to use the CTI membrane, and then I'm going to grow bone with that particular membrane itself. Now, if I have a C defect, which I've showed you, my first choice is to use the tunnel technique. You may also use a ridge split with a C defect, but I will say my priority and my first choice is to use a tunnel with that. If I have a smooth defect, in other words, that it is not a C, it's a distal extension, where I have a smooth defect that runs the entirety of the posterior area of the jaw or the anterior area, then I'm going to use a tunnel technique as my first choice with that. It's going to go the extent or the distance that I needed to extend for the bone growth. If I have an irregular area that is a recent extraction site where the buccal plate was taken out and was removed or that was lost, I'm going to use a CTI membrane for that. In other words, I have no buccal plate that's there. Patient doesn't want to wait for that buccal plate to heal, then and to create a cortical plate. Then I'm going to I'm going to place my implant, and then I'm going to use the membrane to cover the threads on the facial surface. If there is a smooth defect that has some vertical and horizontal loss, I'm going to combine my sponge bone with my tunnel technique. If I have greater than 5 millimeters and good cortical plate to punch through to get good bleeding, I'm going to use my tunnel technique first, but you may also use a ridge split with that. If I have less than 5 millimeters of width of bone, I will only use the tunnel technique for that. And that, my friends, is my technique in an hour or less. There's more to that. This technique is one that typically I will teach in a hands-on setting where we work through and go through a pig jaw. It's a good opportunity to use a pig jaw that you can use to practice on and making sure that you're getting the extent of the membrane underneath the periosteum, and that you're getting a tunnel that you're creating with that. And so I will stop sharing slides, and at this point we'll open it up for question and answers. Let me open up some of the Q&A as well as the chats too. And let's see what we have here. Our first one is for root coverage and flattening the buccal surface. What are the risks of causing a root canal? Thank you very much for that. I did not go deep enough into that. When I'm flattening the root surface, I am not wanting to extend that into or close to the nerve space. And so essentially what I'm wanting to do is, if I have a root that is curved like this, I'm wanting to flatten or level that off a little bit. I'm still wanting to keep the architecture there, but if it's a large curvature, I'm wanting to flatten it just a little bit. I'm not flattening it completely with the root surface. Thank you for that question. Next question, advantages of tunnel versus full thickness flap as it appears as if you have adequate attached gingiva. So the advantages of the tunnel versus the full thickness flap to me is that I'm going to cause less pain to my patients. I'm also going to get more predictability. What I found in my office and the experience that I've had is doing a full thickness flap, exposing the bone itself, and then coming back and placing a membrane or placing a resorbable or a non-resorbable membrane, I'm causing more pain to my patients. There's more chance of postoperative complications that I have with a full thickness flap, and I'm getting more bone growth with my tunnel itself. With my full thickness flap and placing a non-resorbable membrane, I'm having bone growth, but I'm having what I would call minimal or average bone growth. Typically with this technique itself, it's something that I can be in and out of a patient in about a half hour. And so my technique itself is such that within a half hour, I've grafted from 20 back to 18, and the patient is now walking out the door. And so it's a quicker technique to use in my hands. And I feel that it is more predictable for the amount of growth that I have with that. So thanks for that question. Next question comes in: how do you bill for this tunneling procedure? The tunneling technique itself is that I use. I'll pull up the code and I'll give you the code in a minute. Let me open up this. So let me just begin or get my program running, and I'll give you the actual code that I use for that. But the billing of that is such that I do, that I bill that out just as the bone graft itself. You can bill out a couple of things, and that's what I want to get you some of the codes. I'll come back to this question in a minute, okay? once I've got EagleSoft up and going here. What post-op instructions and healing time for the tunneling technique? Great question. So post-operative instructions that I give, at first I used to tell them that I want them to stay away from it. I don't want you touching this. I don't want you around there, just like a traditional bone graft. Instead, now what I tell them is that I want them to take it easy until the gum feels okay. Once the gum itself has felt okay and it's not hurting or aching, then they can begin getting food there. They can begin having a toothbrush on that area there. I don't want them scrubbing it, but it's okay if they actually get a toothbrush over there, a soft or gentle one, or even if they want to do a cotton Q-tip. A Q-tip would be a great one to have them use. What I typically find is that patients are usually more gentle than they actually need to be. And so with this technique itself, they don't have to be as gentle as they would with other bone grafts themselves. Now, I don't want to put a denture on top of this. You know, I don't want to do this and then have a denture fitting right on top of that. If you're doing a full lower jaw, you need to do some temporary implants that are going to support or hold that denture up above the ridge itself while that bone grows. As far as other post-operative instructions that I'm giving them, I'm telling them that I do need them to brush it. The times that I've had problems is when I've had patients that baby it too much and they don't come in with a Q-tip or they don't come in with a toothbrush at all. I see them back in 2 weeks for suture removal and for checking of that. But those are essentially the main post-operative instructions, plus surgery, the general surgery post-operative instructions that you would do. Healing time for this technique, in about 3 months, I'm taking a cone beam. And at that cone beam, I'm able to look and see what is my bone density there. If my bone density is good, meaning that I've got a type 4 or type 3 bone, I'm ready to go right then. If I've got a type 4 bone that's there, I may give it 1 more month. But for my cone beam, I'm able to detect that. On average, what I would say is that what I tell patients is that the majority time I'm going to come in, I'm going to check them at about 3 months, and within 3 to 4 months, I'm ready to place the implant. How long do you wait after the tunneling technique to place the implant? I think that's a continuation, a great question with that. And so we're waiting about on average about 4 months before we're actually placing the implant there. Next question, in the tunneling technique, is the soft tissue pressure keeping the bone graft from being mobile? Raymond, you're exactly right. That is what is immobilizing our bone graft, is the pressure from the soft tissue and from the periosteum. The periosteum is what is holding and encapsulating and keeping that bone compressed up against our ridge. So you're exactly right. That's why we want to make sure that with this technique, we are coming under the periosteum and that the periosteum is able to become our membrane, if you will. When is your next hands-on class? I'm going to let a young, address that. We're not yet doing hands-on classes yet, but would love to be able to have you to one that we could talk about this in a little more detail and spend a day, going over some of these techniques and help you understand a little bit better. How do we do a ridge split? How do we do a tunnel? How do we do that? And when do we do that? And so, not yet, but we're getting closer with our COVID answer, right? What's the difference in root surface conditioning with EDTA as opposed to clindamycin? Great question. There's two. I'll answer that one first. Root surface conditioning with clindamycin or even tetracycline that we used to use back a couple of decades ago is essentially the same thing. And so if you want to use, if you have clindamycin there and don't have EDTA, then use clindamycin. Or you can use, if you have, or if anybody has any tetracycline left over or around or something that you can still get hold of, then that would be another one good for tissue conditioning or root surface conditioning. Thank you. And so there is no difference between that. I just prefer to use EDTA because I have that and use that with my root canals also. So that's readily available in my office. Second part of the question that I want to ask is, how does EDTA help with the reattachment of soft tissue? What it does is, as it conditions the root surface itself, it helps the binding and growth of the gum tissue itself to the root surface. Because we've flattened and scaling and root planing that, we've opened up our pores into the root surface. By placing the EDTA or even the clindamycin there, that conditions that so that it enables the ingrowth of our PDL into, and the beginning growth of the PDL onto the root surface itself. Next question by Justin is, which type of bone graft do you prefer for tunnel technique? The majority of bone that I use, Justin, is really, now I use a cortical powder, for everything. I use that for my extraction socket preservation. I use that for my my sinus. I use that for the tunnel technique. And so I've been using cortical powder for 4 to 5 years, I guess it is, and have had what I think is more dense bone growth by using that particular type of bone graft itself. I typically use a cadaver bone is what I use, but cortical powder from pig or from cow could be used also, but I like the density of that it creates for that. Let's go back up to the original question, which was the codes. And so I've got my Eagle Soft up and running. So the code that I use for bone is bone replacement for ridge preservation. That's the D7953. D7953, that's the one for the bone. As I look at that, if I need to add to that another code, then the other one that I would add would be a guided tissue regeneration. The guided tissue regeneration code, I just closed it. The guided tissue regeneration code is the D4266. D4266 is another one that can be added together in conjunction with the bone graft for ridge preservation, and then the guided tissue regeneration too. Technically, you could also add in a third code, and that would be the D4241, which is gingival flap, 1 to 3 teeth. And so that would be a second one that you, or a third one, excuse me, a third one that you could add. And so the three codes are gingival tissue regeneration, the D4266, the gingival flap, 1 to 3 teeth, D4241, and the bone replacement for ridge preservation, the D7953. Those are the codes that I would use for that. And in any combination of those or a single one. The majority of the time I just use the ridge preservation one. That one, typically the fee for that is going to be enough that it can support my half hour of procedure to do that. All right, let's see, where are we at with other questions themselves? What is the option if this bone resorbs after a couple of years? So timing for placement of your implant is where I think you're getting at with that. And so typically what I tell my patients is that they've got a window of about a year. So if I'm going to place my bone graft now, that within now to the next year is the point in time when I would feel comfortable with having them place their implant. Now, if this is something that somebody's going to be even longer than that, and you're like, well, this may be 2 to 3 years, then if this is your ideal width, then grow a tori, you know, so that when you start to resorb your loss and you lose again from the facial surface, you're going to lose back. So if there's ever any doubt that the patient is not going to follow through within the first year, add more bone into that and grow a tori there. And that way there may be less chance of you having to come back and regraft again other than vertical. You may need to add vertical, but from a width standpoint, you should be fine with doing this, and it should technically be okay for years afterwards. Last question. No, it's not. There's another coming in. Do you use PRF or CGF along with the tunnel bone graft? You could do that, and that would be okay to use if you would choose to do that. The difficulty is going to be creating the opening and having that PRF hold open so that you can then put the bone underneath. And so placing the PRF, if you can do that and place PRF inside of that, and then underneath your PRF, then come and place your bone, you could do that. I just find that it's quick enough and easy enough to just do my resorbable membrane, and I'm getting good enough results with that as it is that I don't need to have extra things. I don't use growth factors for this, you know, that are adding on to the cost of this, because this technique will grow you, like I said, it will grow 4 to 6, 8 millimeters of bone, whatever you need to have, it will grow that for you, because we're getting blood supply, we're stabilizing our bone, we're keeping that from moving, and it's immobile. We're putting it in a good site, and we've got an area where we're able to grow bone. Next question. When would you use a larger particulate size allograft, like 1,000 or 2,000? So I did that in the beginning steps. When I was using and doing this for just root coverage, I was using a larger particle size with that. What I found with my larger particle size was that I was creating, it was hard to actually fill the tunnel. And so what I was having to do was I was having to create a tunnel that was even larger than I needed to have in order to get my large particulate size in there. And so when I went away from my large particle size to my smaller powder, I found that I can place the appropriate amount of bone in that I need in order to grow the right amount of space that's there to have that. And so I've gone completely away from a large particulate, but I did start with that. And so, John, your question about that is a good one, because typically the larger particle size is going to help hold your space better. With this, I don't need to have a space maintainer, because I've got my resorbable membrane, I've got my periosteum that's there, and I've got the bone that's underneath there. And so that is what's led me away from a larger particle size to a powder size. Good question, though. Let's see, are there other questions? That's all from the Q&A. Let's check our chat and see what's coming up on chat. Why membrane in between the periosteum and the bone graft? I thought I could create a tunnel and inject bone graft. This way bone will get blood supply from bone and periosteum. Am I wrong? Please correct. No, this is actually a technique, Larry, that others are using with this that are not penetrating through. And so this is a technique, and I've done this before. This was where again, part of where I started. I went through the process of just packing my bone under there and using my periosteum for that. You will get bone growth that will be there. You will have some. And I'm not going to say you won't. You will have bone growth that will happen as you place just bone itself right underneath the periosteum. You will also lose some. And so that's the tricky part, is how much of the bone you put in versus how much of the end product you will have. And so if you want for just root coverage itself, and you don't need to grow a lot of roots or a lot of ridge there, then you could use your technique, Larry, by just adding by just placing bone underneath the periosteum, by penetrating through and getting blood supply that's coming in, and that should and will give you adequate to give you maybe 1 millimeter or 2 millimeters of bone that's there. And so let's see, what other do we have on chat? You're welcome, Owen. You're welcome, Tuan. My email is on here, and so you're welcome to email me if you have questions. Using sticky bone. Sticky bone would also be good to use underneath there. So if you want to use sticky bone without a resorbable membrane in just the periosteum, that would be a fine technique to use too. I have not used sticky bone a lot in this particular technique, I'll just be honest with you. I found that just with creating my tunnel with my resorbable membrane, that has pretty much been able to maintain my space and to keep the epithelial ingrowth from happening into there. And so you're welcome to experiment with this and to see, you know, what I'm giving you is hopefully a beginning steps of you being able to be a master bone grower. You know, that's the goal of this, is to create a beginning step for you to think about it, to say, oh, what if I did this or added this to this? So this is the basic technique that I use, and it's the one that I use just this week as I'm, you know, doing it on patients themselves. And the one that I'm seeing that I recommended to the guy that came in today, that I said, you should have done my technique, because he's still got to go back for a second stage to get all of the screws and everything removed from his Onlay graft that he had. And he just told me, he says, I wish that I would have known that it would have been easier, because it was pretty hard to have the, you know, the bone graft taken from his jaw. He says, I had two surgery sites that were there that were sore. And so again, I end where I began, which was I'm trying to create things that are less invasive for patients, easier for them, and less painful for them. And so let's see, I think that's all the questions. Great questions, guys and gals. Appreciate that. I think, Young, I'm going to turn it back over to you to finish up.
Thank you, Dr. Platt, very much for answering all these questions. And if there's any further questions, feel free to contact Dr. Platt. I also leave his email in the chat box. So I will go ahead and jump into the announcement. So the Neurobiotech's limited webinar special promotion is going on for our surgical kits. So for today's Dr. Platt's webinar, we are having a special promotion on Reach Wider Kit. The promo code is down here. It's Platt. It's PLATT 0514, and use this promo code for a great discount at the checkout. And if you are interested, you can purchase it on our website using www.neobiotechusa.com. And you can just click on the store right here, and you should be find the Reach Wider Kit under the GBR. And also there is a CTI membrane under the GBR as well that Dr. Also mentioned in his lecture today. So once again, here is a promo code. It's Platt 0514, and this is a limited time, so we offer and expires 2 weeks from today, which is on May 28th. So don't miss out this special promotion. And if you're interested, please check with our sales rep, and they will send this information along with the course evaluation forms after this webinar. And if you are interested in taking our webinars, you can find upcoming webinars in our website, www.neobiotechusa.com, and click the webinar at the top, then you will be on our webinar page. And starting May, we will have 2 webinars every Mondays and Thursdays. So one in the morning from 11 to 12 p.m. and one in the afternoon from 2 to 3 p.m. It's all Pacific Coast time. And all these courses are on first come, first serve basis. So please register in advance and reserve your spot. We also have a great lecture coming up next week on Monday, May 18th with Dr. Mike Chen on fundamental of ridge splitting, and same day at 2 o'clock with Dr. Kent Huang on basic dental implant part 1. And part 2 is on Thursday, May 21st. And also on the same day at 2 o'clock with Dr. Owen Train on all on X treatment planning, surgical, and restorative sequencing. So please save the dates and also mark on your calendar. And here is also more webinars that you can find on our webpage. So the first one is on the 25th of Monday at 11 on the guided implant surgery system with Dr. Spencer Park, and also same day in the afternoon with Dr. Smiler on session 1 of the planning of surgery for zygomatic implants. And the session 2 will be on the following Thursday, May 28th in the morning from 11 to 12. And then on the same day, the afternoon, with Dr. Mike Chen on fundamental of breech augmentation with GBR. So you can also find those webinars in our website here. And now you can also watch previous webinars if you miss any of these great lectures. So just click, it's under the previous webinar in our websites. And thank you very much for those of you who still until the end. And we also request your feedback about the course evaluation. So one of our sales rep will email you the link to complete this form. And this form is very simple, no longer than take 5 minutes. So it should look like this right here. And once you receive it, please fill it out and send it to me as soon as possible. And I want to say thank you again for participating in today's webinar. And I want to say also thank you for Dr. Platt for your time at the office as well. And we really hope to see you again, and stay healthy, and feel free to contact me if you have any further questions. Here's my email, ayong.chuy@neobiotech.usa.com. And we really hope to see you again, and I hope you have a wonderful day. Thank you, Dr. Platt, again. Thank you.